Good evening and welcome to this discussion tonight, which is hosted by the Southern African HIV Clinicians Society and the Bhekisisa Centre for Health Journalism. My name is Mia Malan. I'm the editor of Bhekisisa and I'll be chairing tonight's event. For those of you who don't know Bhekisisa, we report on health policy issues and we interview people like you all the time. And our copy is published on our website and 5 mainstream publications in South Africa. And we also have a monthly television program called Healthbeat on ENCA. Now, tonight we'll be looking at just how badly Pepfar funding cuts have harmed our efforts to fight HIV and TB in South Africa. But as importantly, we'll also look at what can we do to fix this. So what are the solutions? We have 2 hours and 6 speakers, so there will be a really nice mix of a panel discussion and also enough time for comments and for questions from you, the audience. Now, if you'd like to make a question, or ask a question or make a comment, there are 2 ways to do this. The one is that you can enter your question in the Q&A box, and you can do that throughout our discussion. You don't have to wait for the Q&A time to arrive. I will monitor that box. But if you would like to ask your question live, so if you would like your video to be turned on and maybe you have a comment, you need to raise your hand, and you can only do that when the Q&A time arrives. You can't raise your hand now at the beginning of the discussion already. The reason you need to raise your hand is because we need to let our technical person know that they need to turn on your video. So we're going to start off tonight with a presentation, and that will be followed by a panel discussion. And I'm going to introduce our panelists as they speak so I don't repeat myself. We have 6 speakers, and the presentation we're going to start off with is 20 minutes, and it's by the person we all know as LGB, and she's given me instructions that I can't read her bio because she says it will cut into a presentation time and it's boring. So I'm just going to ask LGB Linda-Gail Bekker to start off with, and at the very least say that she is the CEO of the Desmond Tutu Health Foundation, and the presentation is called South Africa and HIV in 2025, the Pepfar funding freeze. Over to you, LGB.
Thank you, Mia, and thank you to the Clinicians Society and Bhekisisa for this opportunity. And my mandate given was to look back before we look forward. So I'm going to look back and bring us up to our present day. So the first 40 years of this epidemic really was an emergency. So if you want to think of it, half the book has been written. And I think we really imagined that the second half would take us into the long haul, the sustainability, the finding the kind of happy medium where we would bring the epidemic under control as a public health threat. We wouldn't eliminate it. We know we aren't likely to do that without a vaccine, but we would definitely get control. And then January 20th happened, and with that, a whole lot of unknowns about funding, foreign aid funding for the world, but particularly for our region, which has really been quite reliant on foreign aid. But let me start at the beginning. Our story starts in 1980. Here you see the man who is known as sort of ground zero, the first person to have been recorded. He, presented with Kaposi sarcoma and pneumocystis carinii pneumonia. We then had a cohort of individuals with these kinds of stories. And then we start to see it being, published in the newspapers. Ronald Reagan, interestingly, took about 3 years to first mention HIV and AIDS. As we all know, it was then discovered to be the disease was known to have been caused by a virus, the immune deficiency virus. And this was thought to have been a sort of jump from a simian variant, and now is very much a global epidemic. And so over time, we have seen numbers increase so that now in excess of 86 million people have acquired this virus and 40 million have died. Here in South Africa, what was going on? Well, interestingly, Chris Hani predicted an epidemic disaster way back in 1992. And the 90s, I guess, due to the fact that there were other governance priorities, HIV largely went undetected and unrestrained. And then we moved in to the dreadful denialist phase under Thabo Mbeki, where there was actually a denial of HIV as a cause of AIDS. Also remember, we had initially in the late 80s very much seen a clade B, typical sort of Western type epidemic, which then through these 90s generalized into a clade C and became a completely generalized heterosexual epidemic. The dynamic duo of Dorrington and Bradshaw kicked into gear even all this time back, really predicting through their models how much AIDS illness and death we would see, and this feminization of the epidemic because of the heterosexual nature of the virus and its transmissibility. We see, women being particularly affected. And of course, because women get infected, they can transmit to their unborn children. And so we see an impact on children, but we also see an impact on children because they are orphaned with the loss of their parents. And so this is the history of perinatal HIV. Initially, 1 in 3 children being infected with HIV, 1 in 2 of those dying by their second year. So an incredible impact on children. And of course, this country contributing in all kinds of ways to solutions, to new innovations, including how to prevent a vertical transmission. We also came to understand the terrible duo of HIV together with TB. So we already had a generalized TB epidemic. You now bring uncontrolled HIV into the environment, and you see the HIV community really bearing the brunt of tuberculosis. So not driving the epidemic, but becoming the victims, if you like, of an uncontrolled TB epidemic. And so here you see first the Canaries being the gold miners who already had a lot of TB on board, also now, really escalating their HIV-related TB. And this wasn't only in gold miners, it became a really generalized state. So here you see Cape Town, the orange line is our generalized TB epidemic. And then in the 2000s, you see the impact of HIV driving a 6-fold increase in tuberculosis. You see a little bump, the blue lines are New York City over this period. And you can see a little bump in 1990 in New York, and that was also HIV driven, interestingly. So this has an enormous impact on life expectancy in Africa. Africa bears the brunt of the epidemic, and you see just a huge death drop in terms of life expectancy. And when you went to individuals, this is one of our longtime employees who described it as losing brothers, sisters, fathers, mothers, children, teachers, doctors, politicians. These people are dying. Well, I'm going to be a little bit Cape Town focused because I have conducted all of my work in HIV in TB, and we started out at the new Somerset Hospital where we had a cohort pre-antiretrovirals, but this is where we conducted the first antiretroviral drug trials. And we did this together with Robin Wood, and I'm just putting this for a little bit of light relief in all of this to recognize that we are going back to a whole nother era in terms of those days. And during that time, we certainly documented how, as the immune system was depleted, we started to see these opportunistic infections, and first and foremost, tuberculosis cropping up as the CD4 count disappeared. And again, just harrowing reminders of that period. This photographer, very well known, Gideon Mendel, coming out and chronicling just the drama and the terrible, terrible dismay that we all felt at the time because of the death and morbidity that we saw. And then, of course, the drug trials start to happen, and we have the miracle of treatment. So we've gone through that era of no treatment, then the proteases, then the NNRTIs, and today we are in the INSTI era. And we've also had a change in policy. And here, the Clinicians Society has played a very significant role, because we as a country have tended to be on the back foot in terms of keeping up with policy movement, but the Clinician Society has driven guidance to make sure that we stay ahead of the curve. And it was early on when we started to realize that antiretrovirals could have an impact not only on outcomes of HIV itself, but also on the outcomes of tuberculosis. So we start to see less opportunistic infections, less tuberculosis in people who are getting at least dual therapy, but preferably triple therapy. And if we can drive that CD4 back up by dropping viral load, then we start to see an impact also on TB. So we start to get this notion very early on. And this, we're talking about the early 2000s here, that actually we need to start antiretrovirals a whole lot sooner than what we were. Suffice to say, one thing we have really recognized in the last 30-odd years is that AIDS is political. It is incredibly political. And of course, antiretroviral therapy was very political. Here you see Natsios, the envoy. I think he's really regretted having said this, but at some inopportune time, he said he didn't think antiretrovirals could be rolled out in Africa because Africans can't necessarily keep time. We were dealing with our own politics of the time, as you see, again, beautifully captured by Zapira over the many years. In the private sector in South Africa, we were starting to see treatment. So treatment cost upwards of 3,000 Rand a month. And so if you were rich, you were able to get your antiretrovirals, and we started to see, first of all, dual therapy, and then moving into triple therapy. Of course, we were very desperate to see what we could do about vertical transmission. Nobody wants to see a child born with HIV. And unfortunately, in the very late part of the 90s, there was reluctance, even though we had started to recognize that regimens could be as simple as a single nevirapine dose. So one pill a day, one pill of nevirapine could reduce HIV transmission to unborn children. And this was picked up by Médecins Sans Frontières, and very boldly, they started a program in 1999 in Khayelitsha in a rollout to prevent HIV. So that was amazing. We also started to see in those very early 2000s work from researchers. First of all, Catherine Orrell coming out very strongly to say, in fact, Africans can take antiretrovirals, and they take them very well indeed. And what's more, we could task shift. So this study to show that nurses were very capable of handing out antiretrovirals and really kicking off our program. This is my look back to the Clinicians Society and my tribute to Des Martin. I wrote this in 2006 when I was editor, but it really does mark this incredibly visionary moment where Des said, we need a clinician society, and we need that in order to teach people how to use antiretrovirals and to get ahead of this epidemic, which was coming. And if you go to the website, you can see that tribute. We knew that we had to teach. This was not taught at medical school, obviously, and so we had to go out and teach our peers, our colleagues, and the nurse force what it meant to take care of people living with antiretrovirals. And I use this slide really just to illustrate that we used a variety of different ways to help people understand CD4s, viral loads, etc. We were at a time when people became aware that in the north, people were receiving treatment and their lives were being saved, whereas in the south, we were without. And we had a number of these sort of surveys where quite clearly people were very keen to get onto antiretrovirals. And so we started, really emboldened by MSF in Khayelitsha. We started in 2000. Catherine Orrell and I took a biscuit box of antiretrovirals to Gugulethu Clinic, and we used to give out treatment to anybody we could. It really meant rationing, though. We had 150 treatment places in a community where 1 in 3 were living with HIV already, and the community was 500,000 people. So I just want to say those dark dark times when we really had to ration life-saving treatment was excruciating. We also came to recognize the power of task shifting. So here you see extraordinary work done by lay healthcare workers themselves living with HIV who said, we can help other people adhere to their treatment very well. And we literally followed individuals, numbers like 174 people in Gugulethu starting antiretrovirals. Look at that median CD4, 83. Again, a majority of women, very sick individuals indeed. And then we were able to really get treatment going. And so we were able to build a building, Hannon Crusade. The government got behind us and Global Fund kicked in and we could really get going. This slide really just underpins that there was no difficulty in Africans being able to adhere to their treatment. So you see very, very good. These were people who were facing death, pulled back from the jaws of death and very able to take their treatment. We looked at what the costs were, and the vast majority of costs in this area was the antiretroviral treatment. So the unaffordability of life-saving treatment was a very prominent feature in the early 2000s. And here you see the introduction of generics coming in, the 3x5 initiative of UNAIDS, and then, of course, Pepfar being launched together with eventually Global Fund. And this was George Bush announcing Pepfar, the President's Emergency Fund for AIDS Relief, and then Obama and both Republicans and Democrats are taking this very seriously. So here's Pepfar, $100 billion, an amazing investment, so many millions of lives saved. The Global Fund, also very important, coming through, not only supplying antiretrovirals, but actually prevention programs too, coming through. And these slides will be available and you can look at the details. Treatment access started to increase. Brazil begins to make generics. Botswana starts a national art program. And in 2004, South Africa launches its antiretroviral program. So we start to see the cost of heart come down significantly. And here the now is actually 2005, and you can see the impact. And that means that finally South Africa starts to recognize that they have to take this epidemic seriously. And through the Pepfar program, which had a very strong faith-based emphasis in those days, you see just one program here, the Catholic Bishops Program, just take off. So these nuns went from giving out Bibles and faith to giving out antiretrovirals, and they did it incredibly effectively. This is work that Des and Robin did to show that they really reached the population, and this is just one NGO. Before NGOs like Inova and Art and Right to Care and the others took over. So we really can talk about the triumph of treatment. It really was a miracle in many ways. David Cooper described it as a modern medical miracle. And of course, now we are working to seeing 95% of people having tested and 95% of people having started their antiretrovirals. Luckily, the treatment of old is not the treatment of today. So in 1996, life expectancy, 39 years. Now we can really expect people to live a normal lifetime. And the Lisbon patient died at the age of 100 years old quite recently. So extraordinary that that handful of pills people used to have to take 5 times a day now is just a pill a day. And Yvette, I always think, is a champion for living loud and living very successfully with antiretroviral treatment, and a real advocate for making sure that we don't have a next generation who also has to face this. So the difficulties of antiretroviral therapy have really also been wiped out by much better treatment now. And of course, this makes it much easier to give it out and to make sure many receive it. So this is really the number of lives that have been saved, and life expectancy has largely been restored in Africa. I do want to take a moment to say we cannot forget the many, many lives that have been lost because of the virus all because of our attitude to the virus. So I do not want to say for a minute that in the 40 years we have not continued to have stigma and discrimination related to HIV, and we cannot in any way underplay that. And of course, the role that bold activism has played in our country and around the world has been extraordinarily important. So where are we today, Mia? We have 40 million people living with HIV, 29 million of them are on antiretrovirals. We still are a part of the world where women bear the brunt. So we carry the majority of women who live with HIV here in Eastern and Southern Africa. We've learned so much. And again, our region has contributed to this knowledge. One very important information is that if people are undetectable on the antiretrovirals, they are uninfectious, so they will not transmit the virus. And if we could get all 38 million people onto treatment and undetectable, the virus would go away. So this is a very important message. It also destigmatizes HIV, so it's another reason we should say there is zero risk if people are undetectable. So we are moving towards the 90-90-90 and the 95-95-95, and certain countries have reached this. Where are we in South Africa? Well, we know we have about 8 million people living with HIV. About 95% know their status. Fewer than should are on antiretrovirals. This is our difficulty, keeping people on antiretrovirals, and that means we don't have enough people suppressed. So we had about 50,000 deaths in 2024 related to HIV, of which 1,500 were children, new infections 150,000, and probably orphans around 650,000. So this is how our epidemic looks today. And of course, one of our biggest problems is keeping people in care. We understand people are revolving all the time in care, going in and out. And so it draws our attention, and I think this is where our panel discussion is going to come in, is that fourth 90. How well are we providing care, and are we retaining people in care in an empathic, differentiated, quality, person-centered way? And of course, now we have to add prevention into the mix. I do want to note that our cohort of people living with HIV are getting older, the cohort is aging, and so we also have to think about HIV now in people over the age of 50 and what that means, including non-communicable diseases. So our reality is we do not have everybody who needs to be on antiretrovirals, and so we have people still at risk of HIV acquisition, and this is the case around the world. So we had still around 1.3 million people infected or acquiring HIV in the last year, and we are way off our targets. Again, our focus is on women and girls, but half of our infections, even in this part of the world, are happening in key populations. So we cannot disregard key populations. And this led a group of us to say, is it possible for us to get epidemic control by 2030? And in order to do that, we are going to have to concentrate on primary prevention. How do we stop those 3,500 infections every day, including the ones that occur in children? So this is truly our unfinished work, that 130,000 children around the world are born with or acquire HIV every year. And I would say this is a real role for injectable PrEP and potentially long-acting treatment as well. So we do need to think about both prevention push as well as treatment pull, and it's good that we have moved into an era where we have good prevention. So it is not just ABC anymore, but we know that a pill a day can prevent HIV. Having said that, we've been slow to get PrEP out to people. Again, our region is making a good contribution. But if you look at the Nora Rosenberg data, and if you listen to Chris Byra's talk at CROI, you would know that we have to give PrEP to many millions of people to avert the at least 250,000 infections that we need to do in our part of the world. And again, we're going to need innovation here. So again, I'm pleased to say we now have not only short-acting PrEP, but longer, less frequently dosed acting PrEP as well. And along with the injectables, we have the promise of a monthly pill annual intramuscular PrEP and infusible PrEP coming as well. And you will have all seen this data from 2024. And I raise it just because we have these wonderful opportunities to actually really make a difference in primary PrEP, primary prevention at a time when resources are few. So I'm going to start wrapping up to say, we have made extraordinary progress, not only in terms of implementation, but also in innovation over the last 40 years. But we have not contained the virus. And some of this is because of communities, social, community, political, and economic obstacles get in the way of getting to this. Bad policies that reflect ideology rather than science stop the most vulnerable from accessing the services they need. And I've already mentioned how politics really get in the way. Stigma gets in the way. Right from the beginning, we've had to deal with people who've been on the edge of community, and we continue to leave them there. So we have to really worry about the people who have been hardly ever reached. We've reached the bulk of people. And I want to say this is what Pepfar and foreign money was helping us do in this country, is reach through communities, through non-traditional services, differentiated service delivery, up into those very high branches, which we have not reached. So we reach those who haven't been tested. We reach those who have tested but haven't been linked. We reach those who've cycled out of care, those who struggle to suppress, those who have been tested but aren't preventing, those who have disengaged from prevention, those who can't or won't attend our traditional health facilities. That's the work we have to do now. So will we reach the end of AIDS? Well, we were kind of off target even before this funding crisis. I believe we have the tools to get the control, but we're going to need to have some real responses. And I'm hoping our panel will unpack some of these. But there's no doubt community is key in all of this. Funding was already short before we had this dreadful, shock. And of course, here is the shock. So on the 27th of February, most USAID-supported cooperative agreements were terminated. The CDC have in part been allowed in a temporary form in some programs. And again, those on the panel can expand some of this. Implementing partners who carried these out have had to furlough or retrench their staff. USAID structures have been dismantled. And we are waiting to see if Pepfar reauthorization may happen. 8 billion has been invested in South Africa so far, initially 100% as an emergency fund, but then we whittled that back. And recently it's been more about prevention and technical support. $460 million represented the 18% of the annual budget. And this really was to do those last mile activities and provide the technical support and the health system strengthening that would get us to epidemic control. So it involves a great number of implementing partners who have a huge number of staff, including data capturers, and were mostly deployed in high burden districts. So the program mostly catered for out-of-facility community-based care, differentiated care, orphan care, gender-based and intimate partner support, prevention in all of its forms, early access to innovation, and here's the LEN doses we can talk more about, support for CBOs, support for community monitoring, data collection, and technical support at multiple levels. I'm not going to go into these details, but there have been models that have been already made and published to show what the impact is of losing funding in our region. We published something in the annals that showed that in the next 10 years, if Pepfar goes away, this 1/5 of our funding, more than 500,000 new infections and more than 600,000 deaths will occur. And this will cost our annual budget quite significantly in 10 years' time. And Gesina Rathmay and her chommies have now also put out a model which is in MedRex, and you can go and read about that. I again don't want to underplay that this has been 40 years of profound social impact. And Jonathan Mann said, maybe this is the most important thing, is in South Africa, at the time of plague, we did not flee, we did not hide, we did not separate ourselves. And again, he said, AIDS remorselessly highlights and exposes the weaknesses, the inadequacies, the inequities of our existing health and social systems. In this way, the fight against AIDS has become part of a broader fight for health for all. And truly, I think if we lead with good responses for HIV, we can follow with good responses for global health. And now I want to remind you all that way back to 2000, when former President Nelson Mandela got up at the end of the AIDS conference in 2000, he reminded us that this is something we cannot do primarily by ourselves. We need resources and partnerships. And the constant theme in all our messages in this interdependent and globalized world, we have indeed again become the keepers of our brothers and sisters. And this is epitomized. And of course, our great patron has said, this is the new apartheid. We have to keep going. We cannot leave anybody behind. And with that, Mia, I'll end. I may have gone over my time, but it's 40 years of history, which I hope I've covered sufficiently. I think the message is that we came from a time of despair. We've made amazing progress. And of course, we're very concerned about where we will go from here.
Thank you very much, Linda-Gail. It was a really comprehensive presentation, and not just showing us the extraordinary progress that we've made, but also the unfinished work that we now need to face, and that scientists like you and many others who have joined this webinar now need to face without the great support that we received from Pepfar up until recently. I'd just like to point out that we did invite the Acting Deputy Director General for HIV, Rampelani Modawani, in the National Health Department to this webinar, and his office indicated that he will join. We haven't seen him yet. Rampelani, if you're here, please do raise your hand so that I can point out you are here and also ask you to respond. But in the meantime, we're going to move on to our panel discussion now. And just to recap what LGB said is, in February, the Trump administration ended over half of South Africa's Pepfar funding for projects who were funded through USAID. The National Health Department says that's roughly about 56% of our funding from Pepfar. And as Linda-Gail also mentioned, the ones from the CDC, the Centers for Disease Control and Prevention, are still running, but they only have budgets until the end of September, and we don't really yet know what will happen after that. Now, we've seen NGOs shutting down virtually overnight, and clinics for particularly key populations that Linda-Gail pointed out is so important to address now, for instance, sex workers and transgender people. Those clinics closed down very quickly, within days. And also PrEP projects for HIV prevention and studies like the Catalyst study, they closed down, and as Linda-Gail pointed out, thousands of workers lost their jobs in a very short period of time. Now, I'm going to start off by asking each panelist an opening question to start at the beginning, to say, what impact have you seen since February? Have you, in your field and the projects that you work with, have you seen people struggling to access treatment or HIV prevention medication? And have you seen adherence problems? Let's start with Sibongile Shabalala, who is the national chairperson of the Treatment Action Campaign. Sibongile, you have projects where you deal with patient access on a grassroots level. What have you seen?
Thank you, Mia. Can I switch off my video? Can I switch off my video because my network is not stable, so that I keep my network? Thank you. Just to respond to your question, we have started to see a lot of instabilities on the ground. Just to point out a few of the comments from the people that we have spoken to. One of the KPs says, I was unaware that Engagement Health had closed due to stop work order. I received services in December and got 3 months supply of ARVs. Now I'm worried that I'll have to return to work Zakhele Clinic for HIV treatment, and I'm not comfortable seeking health at the at a clinic due to my previous experience. And another healthcare seeker from Matatiele Community Clinic, she says she went to the clinic because she had her 3-month supply and she was due on the 25th of February. And when she got there, unfortunately, the service was very slow, and unfortunately, she was only given 14-day treatment. And when she asked to say why is she given a 14-day instead of 3 months, and then she was told that because of the step working order. And another patient also showed dissatisfaction after going to the clinic to take her bloods, which she went to the clinic around 6 a.m. but the clinic started to work at 9 a.m. and she had to spend the whole day there, and she experienced shouting and unhelpful staff, rude, and her file, it took longer for them to get it. So what does that mean? It means now without the Pepfar funding or Pepfar support staff, now people have to spend more time in facilities, and also KPs, as Linda rightfully said, are struggling because the drop-in centers were just closed down without any communication, without any referral letters. So now KPs are forced to go back to health facilities. And through our Richardson report, we know for the fact that key populations are still stigmatized in facilities. I was reading one of the articles from Health E this morning, which showed that a sex worker was denied health services because she said she is a sex worker when she was asked when she was asked what is she doing for living, and she pointed out that I'm a sex worker, then she was denied ARV because they said government doesn't have money to waste on sex workers. So that is the situation on the ground, and that's what people are going through on the ground now.
Thanks very much, Sibongile. Let's move on we have Koli Butulezi from Sisonke, the Sex Worker National Movement here. What have you experienced? We've heard Sibongile talking about a sex worker who's been discriminated against at a government clinic. What is your experience with your members, Koli?
Thank you so much. I've got the same challenge of a network in case it cuts off. I thank you so much, Leadership Sibongile, for bringing that to your attention. Good afternoon to you all. I have my colleague that I would suggest that she speak on these issues. Her name is Maneo Musia. We've grown our staff, we've capacitated our staff, so it will be good because she's the one that is working on the ground as a peer educator champion, field worker that is engages with the sex workers on a daily basis. But I will chip in also with more comments. I might also put some, I think, on the chat. Maneo, are you ready and are you okay to talk on this, to share the lived experience of sex workers that you're facing currently? Thank you so much, colleague. Thanks, Mia.
Okay. Good evening, everybody. As Sis Koli has mentioned, my name is Maneo Musia. I am the Sisonke peer educator, and I'm also civil society forum coordinator, and I also do DDP trainings, dignity diversity projects. So now, just to add also on what Sister Sibongile has said, now one of the challenges that we're getting, at times they don't even ask you what type of a job that you're doing, because remember now, when the funds were cut off, some of the sex workers were able to receive referral letters. So now when they reach the clinic places, health facilities rather, as soon as they see that emblem, Vets RHI, automatically they know Vets RHI works with sex workers. So a lot of sex workers, they get turned away. And also that some of the sex workers were only given a little medication to go through with. And yeah, for now, Sister Koli, can you please chip in?
So these are challenges that I think we've been facing for the mere fact that our service beneficiaries were accessing services to donor-funded clinics. If now you bring the the referral letter that it has the logo of the organization, that on its own, it's a stigma. And I do agree with the leadership, Sibongile, to the point that highlighted around the issue of the clinic being slow. I think it's going to be like that now, and we expect to government maybe to chip in, sort of like looking into maybe the previous employees of those NGOs, because they are well sensitized, they are aware of working with us as a sexual community, they are really, I think, educated in working with the diversity of our communities, because we have trans, we have female, we have male sex workers. It has actually taken, I think, a toll, this situation. I remember last time also we were trying to refer a community LGBTI member to the clinic. She struggled, I think, for 5 to 6 days without medication, because we could not get exactly the medication that she's been getting within the VETS-RHI trans clinic. So these are some of the challenges that I think we are facing. And some of the incidents that have been reported and brought to our attention are that when sex workers are asking for more condoms, because some they openly speaking about their profession. I mean, anyone will be confident about the work that you do. Some they've been denied a box of a condom. They are being given a limited number of pack of those condoms, and it is very concerning, especially during this time around, because also in the CBD there were reports that there were some former brothels and some areas where sex workers operate. Management would sell the condoms to them, and we're realizing now that this situation is going to be coming up a lot, and the agent interventions, I think, will be needed. But we're struggling because currently we do not do any outreaches because we also got a shortfall within the organization. But recently we had approached by the Department of Health, but they can't fund outreach field workers to get into outreach, but they needed us to assist in terms of AMALOS to follow up, but also track and trace, part of the 1.1 million patients that needs to be initiated. So we see a lot of crisis, and I think the provinces also will be reporting, because there's a little project that I think we're doing within the organization in making sure that it's part of the emergency in attending healthy related issues. I'm sure in the next meeting on in other platforms, we'll be able to present, I think, a geographical of the footprint where SAHCS have provinces around the issues that the sex workers are facing in this crisis.
Collie, thanks, Collie. Just to check, so are you aware of some sex workers who have stopped their treatment or not taken their treatment regularly, so not each day, because of these funding cuts? And are you aware?
Definitely there will be, because also we're struggling a little bit. We haven't been doing, I think, fieldwork outreach for 3 months now. We're trying to sort of like shift and move money and see where we can get funds so that we can do the special outreach, because our main activity within the organization is the creative space where we invite sex workers to gather in one space. Then we can be able to get that kind of information. And another activity is the outreach fieldwork that our team is doing, which is on hold currently. But we did get some little bit of budget, but I'm not sure we'll be able to reach out in all places. So I know that for a fact that definitely there will be lots of cases, because even the trans LGBTI member of ours that reached out to us went into WRHI, and she contacted me to say, well, the clinic is closed, I don't know where to go. So there's a lot of cases. I think there's a lot of defaulters that I think we're going to be experiencing, and I'm definitely sure that there's a lot of defaulters that are happening currently because of the short notice of the referral. And in clinics, they don't even want to give sex workers medication, even if someone is a container, because it should be like they need to have a track record of how are we tracking those that we've given them a refill, so that when they come in the following appointment, and then they'll be able to bring whatever is needed. But then people are denied the referral letter that we got from WRHI. I don't know in other provinces, but I think we'll be able to gather that information as well. But it's just some of these examples that we're using, because we know that our communities, key population dependent on funded donors clinics. So in this situation, it's going to be a lot of crisis. I've got the sleepless nights myself. I don't sleep enough because I'm trying to think how best we can serve our communities, because we're meeting them through outreach. Some they don't have phones, some they've got phones, but it's so challenging. I think the crisis is actually taken a toll even on us as employees that are also sex workers and employees within any organizations that have actually done this good work in making sure that we're fighting the HIV pandemic in the country.
Thanks very much, Collie. Linda-Gail, I want to ask you to respond to that quickly. I'm going to move on to Kate Rees after that because I also want to talk about ANOVA and also get her response. But if you have the situation where you don't have outreach teams, you don't have counselors to go and check if people are getting their treatment, and you don't have key population clinics, what do you see? Have you seen it play out in terms of increased viral loads or less adherence? Is there any data that's been collected on that? Or is it too
Yeah, I
short?
think this, this is the nub of the problem, right? So our data collectors, many of them were Pepfar funded. As you hear, the community, monitoring systems were donor funded. So if you don't measure something, you won't even know that it's a problem. So unfortunately, to date, a lot of it has been anecdotal stuff. We know that clinics are closed. We know that counsellors have gone away. Counsellors who normally do testing are no longer employed. And even in a province like mine, where I'm in the Western Cape and perhaps not quite as hard hit, we weren't quite as dependent on donor funding for a lot of functions. Kate will bear me out on this, was ANOVA counsellors who serviced a lot of the clinics where I work. And I know that I've had to replace those counsellors with Desmond Tutu counsellors simply because those are the people who do the testing. And so what I'm hearing from nurses is we don't have time to do testing. So these people are being asked to come back tomorrow, or as has been pointed out so beautifully by Sibongile, Collie and others, is they're actually being asked to, they're being deferred. And we know that's the worst thing you can possibly do, is come back on another day, because they're people who might have been sitting there a little bit, a little bit on the fence about their treatment, maybe finding it difficult, but able to do it because it was convenient and accessible and easy to do. You meet hardship when you've already dealing with a lot of hardship in your life, and you fall off the bandwagon. And then it is anybody who's had to go back onto treatment for any treatment or any other kind of thing you have to do daily. It's really hard to get back into that position. And so I do think I would absolutely concur with my fellow panelists here that there is no doubt that people are defaulting off treatment at the moment. There are people who haven't been tested, who should have been tested, and there are people who simply are not accessing prevention, because prevention really is something that depends on, I'll pick it up because it's convenient, because I can do it, because I know that, it's there. And if there's difficulty, why would I add even more hardship to my life? And we spent the first 30 years of the epidemic recognizing this is what we needed to do. We needed to differentiate care. We need to make it tailored to people. We need to make it accessible and easy. And just overnight, we've lost all of that, that sort of critical recognition of how we should run our services in order to bring this epidemic to its knees.
Thanks, Linda-Gail. Let's go to Dr. Kate Rees, who's a public health medicine specialist, and she works for the ANOVA Health Institute, where she provides technical support for the delivery of HIV and TB services. Now, Kate, ANOVA has been hit really hard by these Pepfar cuts because they received the largest amount of Pepfar funding in the country, and also almost all its funding from Pepfar. What has happened to your patients?
Thanks, Mia. So as Linda-Gail was saying, I think one of our major challenges is that our means of monitoring the program has really decreased, and it's really challenging. So, for example, what we're seeing in one of our biggest supported districts, which was purely USAID supported, and so now has no more technical support, that the numbers of people on ART have dropped down to 2022 levels. We've gone back years. We hope that is mostly data capturing, and that some people, at least of that chunk, are on treatment, and that they're not, their records are not being updated. But we don't know, and so it becomes incredibly difficult to monitor the program. Similarly, with key populations, with a lot of the programs that we're working with key populations, we just don't know. The kind of government indicators don't track key populations well. They don't even disaggregate gender very well for some of the indicators. And so it's very difficult to now understand what is happening with the program and with our populations. One of the data sources we do have is the NHLS, because they don't rely on data capturers in clinics. And we're seeing that viral loads, CD4 counts, tests for young babies have all dropped in comparison to last year this time. And it's nationally, we're kind of seeing around a 20% decrease, which is huge considering that Pepfar supported 27 districts and many of them are still operating through CDC. Again, one of our big districts that we supported that lost all its technical support, we're seeing about a 30% decrease in people started on antiretroviral therapy this month compared to the same time last year. And I think one of the things, those new people starting on treatment, I think the clinicians on the call will really understand that those are not necessarily new people, but then people re-entering care, and that is how people engage with the clinic. And so for those numbers to go down is a really worrying sign of what's to come in terms of maintaining people on treatment.
Thanks very much, Kate. To look at solutions, so ANOVA has received some gap funding, but very small grants. Are those grants helpful, or are they almost like making things more difficult because you've got a little bit of money, but not enough to do what you want to do?
Yeah, so I think by this time, and it's been, it feels like such a long time, it's been a few months since the stop orders, it's too late to go to small transition funding or to rescue these programs as they are. We need a concerted, coordinated effort from government, from private sector, from the NGOs, from our civil society groups. We need an emergency plan, and we need it all to kind of gel together. What we're seeing is that the funders really want to help. They want to contribute. But the Department of Health is not, it's not necessarily helpful for them. They need ongoing, sustainable support. They don't need, a little bit of money here and a nurse here. They need like a long-term plan. And so that's really what we need as a country.
Thanks, Kate. I'm going to move on to the president of the South African HIV Clinician Society, Dr. Ndviwe Mpotulu. Ndviwe, what do you think the health department hasn't done? And what should it be doing?
Thank you, colleagues. And I think our first presentation by Prof. Linda-Gail Bekker was very important. Because you see, we from the society, if you understand the history of where we come from in terms of the HIV program in this country, you'll understand that from history, we learn that people don't learn from history. That's a lesson from history. People don't learn from history, and people who don't learn from history repeat the mistakes of history. And I think we have had, one of the co-founders of the HIV Society as early as the 1980s, warning the then apartheid government that there is a problem here. There's going to be a problem if they don't act. And then the post-1994 government was also warned, it didn't act. So we are worried that we think the program is going to unravel in real time in front of us if there are no exact plans and programs from the government. So it is hardly reassuring for the government to tell us that there are plans. We need to see the plans. And also history tells us that one of the reasons that our program is so successful is because we worked with the civil society, we worked with the people living with HIV, we worked with faith-based people, worked with clinicians, everyone was involved. So we've not heard of any plan where we've been called or any meeting where been called in one room to discuss this, because there's no one who's got all the solutions. And I think from as clinician, I think we worry that, for example, who's testing new patients, people living with HIV. So it means we're going to have less people being diagnosed with HIV. We're going to have reduced personnel for tracking people who are lost to follow up. We're going to have less people working with the young people and adolescents for PrEP, and so forth and so forth, and people presenting with advanced HIV disease and so forth. So, and research is being impacted. So we are really worried about that. We've not been called in any meeting to come together with our colleagues here in the call, because we've got the experience. I mean, we've got the experience in this country of almost 20 years, even going further than 20 years. So we think there should be a meeting that calls all of us together. We come with solutions. Thank you.
Thanks very much, Ndwebe. Is there any other Tabu Mashiko, I see your hand. I'm going to get to you. I see you've raised your hand. I just want to hear, is there any other panelist who wants to respond to what the health department isn't doing what it should be doing? So we've heard about we need a coordinated plan. They don't have a lot of money. What can they do without a large pot of money to help? What can they do better?
I think let me put my thing on. I think we shouldn't just be throwing money at the problem. We should come together, sit and analyze what are the problems, how can we sort out? Because if we say we need this, how do we quantify that money? We don't know how much money is it. But if we've got colleagues who work with key population groups, we've got researchers like LGB, we've got people from ANOVA, we've got clinicians, we've got civil society. We'll then be able to say these are the problems. So we can't say this is the amount of money you need. So I don't think the problem is the money. The problem is a plan or a strategy. I think that should be the first part, rather than saying we want it. The problem is money. Thank you.
Thank you. I see, Kate, you've raised your hand.
I think one of the things that we really need is an understanding, a really brave and strong understanding of where the gaps are going to be, where the gaps are, and a real prioritization and focus on those pieces. Instead of just going on business as usual, trying to figure out exactly where the gaps are and how we can fill them. So I'm thinking about things like PrEP, for example, which we haven't really talked about that much yet. Obviously LGB did, but there's a huge gap now with demand creation, with peer support, with all kinds of things around PrEP. So I think really focusing in on what are those key priorities, and we haven't seen that.
Thanks, Kate. LGB, do you want to respond to that? Then we go to Sibongile after that.
Yeah, I mean, Kate said it beautifully, the word prioritization, and I think in Devi also raised that. I think even before this happened, Mia, we had to say, look, we've got 5 years to reach our 2030 target. What do we need to really throw our efforts and energy at? And probably the writing was on the wall that Pepfar would reduce its funding given the new administration either way. So I think we were kind of, imagining that this train was coming. I don't think we thought it was going to drive it straight into the station and blow the station apart. But we saw the train coming. And I think this exercise really now needs to be catalyzed and done with a huge amount of energy and with many minds in the room. What are our best buys and how do we get those out to the people who need it most as quickly as we can, and who should do that and how should we do that? And yes, I don't think government as its own is going to be able to solve this problem. So I think if we saw government leading, you would see other funders being able to step in and say, okay, let's put this a little bit like we saw with COVID. We saw amazing leadership during COVID, right? And then private funding kind of followed in its wake. We're not hearing that this time around. And my concern is because it doesn't feel like anyone's in charge. And that's really concerning. You know, I mean, I think we've been putting up our hands and saying, we can help. What can we do? You know, we asked the implementing partners to list all the activities they were doing. There's your clue. This is what they were doing. This is what's gone away. You know, maybe we don't need all those things. That some of those were luxury items. I admit, you know, fully. But how do we now say, okay? And I must say again, one thing we've learned in DeViwe over these 30 years is we're very good at rationing and prioritizing, right? There are parts of the world where money is never an issue, and those people don't know how to say, okay, let's get the best buy. Here's the investment case. This is what we really need to do. This is what the epidemic is telling us. So I think that's absolutely key and critical. And then we need very urgently ways to be able to tell what's happening where and how we intervene, because we don't want our hospitals full of people with tuberculosis and Kaposi sarcoma again before we move in to figure out what to do. And that, you know, sadly is going to unfortunately be the situation if we don't move quickly to figure out how to fill the gaps in the best possible way. And I'm afraid it isn't just people must move into public sector clinics because the pills are waiting for them there. We did that for, you know, 10 years and we failed. So that is not the answer to this, you know, the solution to this problem.
LGB,
Thanks,
sure, I have a question. So you mentioned that one of the biggest gaps now is we don't have enough data capturers. So they will tell us where the gaps are, right? So would one of the first steps be for us to find funding for data capturers?
Sure, or have different ways of making sure, again, you know, coordinated leading from the front to say, what are our early indicators? Who's monitoring that? How do we pick that up? Maybe it's a tiny bit of money to give it back to, you know, to TAC and their cohorts to go out there and gather it in the field. Certainly every hospital should be immediately notifying upwards to say, I've got an AIDS case, this is what's happening, you know, etc. I think we need some early indicator alarm bells that Kate was talking about. You know, we can to a certain extent rely on NHLS or whatever, but even there, the horse is down the road to a certain extent by the time, you know, some of these indicators are coming in the door, and the data is only as good as that was, you know, how it was collected. So also, if it's not there, is it because it wasn't done or because there was no one to collect the data? So I think these are this is part of the plan that I think we need really, really urgently.
Thanks, LGB. Sibongile?
Thank you, Mia. I think I want Linda-Gail just took words out of my mouth, and when she was responding on what needs to be done. But also, I just want to say we need really leadership of National Department of Health in this. We need the proactiveness of it, not the reactive, because we have learned and we've spoken about that. When we are reactive, we are dealing with the problem late. But also, we don't need them to divide the civil society, because recently that's what they are doing in dividing the civil society to say we are going to talk to who and not talk to who. But the plan that we need, what we are calling for, we are not getting. So we really need them to work with everyone, and they should remember that we have all these gains because of working together, as Ndivue has said. When they need data capturers are living in communities. They can take them to the clinics, are happy to assist where they need, there is a need. We started volunteering, making sure that our people survive, and we survive as people living with HIV. So if we have to do it again, let it be so that we save our lives. So we don't need politics, we don't need mind games, but we need a proactive response and working together, all stakeholders in one room, so that we can think together to say what is our next move and work together so that we can be able to close the gap.
Thanks,
Thank
Sibongile. Koli, you've raised your hand.
Yes, thank you so much. I was wanting to highlight a few things that are key impact in the situation, but also in response to these challenges. As uSisonke and our allies, I think we should call our government increase funding from other sources, including local and international government and private donors. However, the gap that is left by the loss of Pepfar funding remains a serious challenge, I think, to the healthy, safety, and the rights of sex workers, in particular, key population. So this situation, it also highlights the fragile of services provision that are impacted. And I think we need special outreach and the government to revise their budget that they have currently so that we attend in the matter urgently of making sure that the services get to the communities. Because as I indicated earlier, that one of the government department approaches us to work with them around the tracking, especially our key population that are sex workers. But if they don't have money even just to fund the outreach, for our team to move from point A to point B, it's going to be difficult because then we can't utilize other donors' money to do government's money. So there is important need of revising and also check what budget is there, and then they can ask permission to whoever is funding our Department of Health. And also the extension of our operations of hours. I think government also need to look into that because there's going to be packed off clinics. People are going to go back home without being assisted. Then healthy workers that are currently working now, they won't be able to manage the number of patients that are coming into healthy facilities. That's when they also lose the patient because, I mean, the workload is going to be piling up. And key impacts, several key issues to this crisis. The HIV treatment itself, the access to healthy, those are important things that I think we need to prioritize because sitting and strategizing for Mina, I think it might also take time. If this budget, can we be approached as key population because we know where to found our communities? We can also play a huge role in making sure that people are adhering to medication, people are referred, because now what we do with our peer educators, they work with the clients, with the beneficiaries, the service provider to the clinic so that they prevent the stigma that is happening. Being asked of where you're coming from, what is the what kind of life or work do you live? I think it's because of that referral that is coming from the non-funded government. I think also it would be important to gather those cases and making sure that we have a lived evidence that you can present it to say, we have actually spoken about the stigma. We've tried to eliminate the stigma in our country, but it's still happening. So those, I think, are some of the things that we need to be more because we need money to move from point 1 to point B. We cannot walk, a province are scattered. So it's important that there must be at least a little bit budgeted that to be able to provide. Also, government to make use of all the service resources that they've had. I know that government, they've had mobile clinics. Can they provide mobile clinics maybe in each key population organization so that then we're able to reach out to our communities, because defaulting is happening currently as we speak. Not every sex worker is using the government health facilities. So this is a serious crisis that I think it needs action, because we've had back and forth meetings since this crisis started. So it is important that I think we get into action, how best we can do this, because if we can get a car, if we can be borrowed a car, we can be able to drive and put petrol and then reach out to our communities, because they work online, they work on the street, they work into brothels, they work in different parts of South Africa. But also to recognize the intersectionality, because our communities within the sex work, we have a comprises of all the key populations that are there. So a partnership also, I think it is important that we work with other sectors to try our best and reach our communities that are on the loose due to this crisis. Thanks.
Thanks, Koli. So there are two things that really emerge is we need money, but we need leadership from the health department and from government. And it seems like no one is really in charge. So I would just like to re-emphasize that we did ask the National Health Department, Rampelani Morawani, who is the acting Director General for HIV, to come to this webinar. I don't see him here yet, But Rampalani, if you are here and you're perhaps here under a different name, please do raise your hand if you would like to respond to some of the points raised about the health department here. In the meantime, I would like to read some of the comments and also ask some of the questions in the Q&A box. If you would like to ask your question yourself or make a comment, please raise your hand and we'll give you a chance. I just ask that you keep it short, that you keep it to 1 to 2 minutes and don't take up a lot of time to make your comments so that there's space for everyone to do so. While we're waiting for that, there is an interesting question. Where is SAHCS, the South African National AIDS Council, in this important country conversation? Prioritization and realignment of the response. If there is someone from SAHCS who is attending and would like to respond, please do let us know, raise your hand. I don't think any of our representatives serves on committees of SAHCS, or am I wrong? Do you, for instance, or is anyone involved deeply in SAHCS activities? Perhaps the TAC and some committees?
Yes, we are participating in SAHCS, and unfortunately at this moment, SAHCS Civil Society, it's in a very same situation where we don't have the plan. Yes, the Department of Health did engage SAHCS Civil Society, and we had a plenary, I think, late last month. But there is nothing tangible that we can point out from SAHCS to say, this is what we are getting. So at this moment, SAHCS is also frustrated. Yes, we are engaging with Department of Health, but there is no plan so far. We are still looking for that leadership. We are asking for that leadership. It is so unfortunate that the DP is not responding to these issues, and we are not hearing him saying more, because we were expecting him to lead as the chair of South African National AIDS Council, but unfortunately that's where we find ourselves. So there is no political will in terms of addressing this issue, especially from the President's office.
Thanks, Sibongile. I'm going to read a comment, and there's also a question at the end from Notloleng Mabena, who says, we also cannot ignore the current human resource crisis that is happening within the Department of Health, with policies on overtime and sessional clinicians dramatically changing. If the government right now does not seem to even have the capacity to serve public service patients in routine services, how do we creatively address this problem of disintegration of the civil society and NGO services, taking into consideration the problem that currently exists in the system? Does any panelists would like to respond to that? How do we do it when there's already limited resources?
Yeah, I'll pop in here to say that I agree that this couldn't come at a worse time, in that we clearly also have a health system that is kind of on its knees. I mean, you read about this in the news every day across the country. So this is why I think it doesn't detract from the fact that we need a plan that takes that into consideration, that we honestly get in a room together and say, given the constraints, given the difficulties, because I think that having a plan and being vocal about what needs to be done may unlock additional funding, not only from Treasury, but also from other external sort of funders. So I think the worst scenario is this apparent paralysis and lack of movement forward, and the sort of lack of urgency around it. I saw, our colleague Francois Fenter's comment that we need it, but it may not be perfect, but it needs to be urgent. Time is mattering here a lot.
Thanks, LGB. It sounds like someone may have their sound on. If you are the person who hasn't muted yourself, please go ahead and do press that mute button. Kubendran Pillay says it may be early days, but does anyone think that this crisis not gives the health department an opportunity to show on how the National Health Insurance team will take the lead in such matters, or is the department working in silos? Which panelists would like to respond? Perhaps Kate, you may have something to say.
Thanks. I mean, yeah, there's a tricky question for me to answer as an outsider. I do believe that Prof. Crisp is involved, very involved, and I don't think that I think the NHI is very strongly integrated into everything that the department is doing right now. I think it's one of the reasons that, you know, it explains a lot of the decisions that they're making is their turn towards the NHI, and I don't think it's not on the agenda. I think they're all on the same page in that regard. But I'm an outsider, and I can't really answer that. But yeah, there's a lot of, in some ways, there's a lot of opportunity for NHI in this crisis. We've got different role players that can really come to the party and step up, and we've got, you know, a space for innovation in how health services are provided in terms of nurse-led private sector partners, in terms of partnerships between the department and private sector, and different ways of employers funding services. So I think there definitely is a lot of opportunity there. And whether the timing is right, I mean, I hope we are able to take advantage of that, because that could really help and assist those people who are just cannot sit, you know, with expanded waiting times or extended waiting times, who are just not able to sit in the clinics. So it could be a win-win if we're able to kind of harness that opportunity.
Thanks, Kate. And what do you think? Is this the time for the NHI to get its act together?
Unfortunately, I'm not really sure how they work, because I'm also an outsider. But what I know, Mia, what I know is that we've got experience in the HIV program. We've got expertise in this country, and we've got health workers who are very agile. Remember, in the time of COVID, what happened? I mean, everyone came in and contributed. I mean, in the clinics, security personnel was opening files, you know. So we've got that expertise. And if you look at the COVID committee that was constituted, then if you look, I mean, more than 70% of that committee were people from the HIV space, because they've got expertise. So we have the expertise, we have the people, we have the energy, we want to work. So we just need coordination. So we just need someone to coordinate and lead. And then you'll see, I think not that will be a magic bullet, but I'm certain that we will see some movement if we do come to. I mean, the expertise in this country are amazing. The health workers in this country are hard workers. I mean, we've got colleagues in the rural health sector organized. We've got, I mean, we just need leadership. We are ready. We just need leadership. Thank you.
Thanks very much. And in the defense of some of the health department, I interviewed Nicholas Crisp, who heads up the NHI, and he was the one who came up with a figure that we need, what the health department says they need 2.82 billion rands for the next financial year to be able to appoint staff to replace their Pepfar projects, which they don't have. They don't have the money, but he was the one who compiled that document and who helped to gather all the information and make sense out of the data. One of the questions, interesting question that came through from people when they registered was, what is the future of health NGOs in the current situation? Would we even have HIV and TB NGOs if we don't have Pepfar funding? Sibongile, do you want to respond to that?
Yes, I can respond to that. I do believe, Mia, that we will still have HIV NGOs in the space because since we have not won the fight against HIV, as people living with HIV, we are not going to back down. With or without funding, we'll continue to do the work. Like for instance, TAC is also affected by the Pepfar funding cut. We had to release around 148 staff members out of 200 and something staff members. You can imagine now we're operating with 43 staff members. But, surprisingly, when we engaged with the retrenched staff members, they were willing to say, we are going to work on the ground because we've been part of the struggle, we've been fighting, we've been working for our community. So we'll continue, even though we are not paid, as long as you will support our travels from point A to point B and all those things. So by doing that, and also there are funders who are out there we are talking to them, who are willing to support us. They might not be able to support us at a huge scale like Pepfar was doing, but there are funders out there who are willing to support the work that we are doing as NGOs. So I think if we can continue to work together and also engage more funders in terms of funding HIV and also like encourage funders to fund more HIV programs, then I think we can still continue. And I don't see HIV NGOs dying anytime soon, not unless we want them to die. But as communities, as people living with HIV, I think also Collie will say the same. We are committed to the work that we are doing because we are mostly affected by HIV.
Thanks, Collie. I'm going to get to you directly after my question to Kate. Kate, a place like Nova, at which capacity is it functioning now? How much of your activities that you used to do are you doing now, if we talk about the future of HIV NGOs?
Yeah, so we are doing Global Fund funded activities, so those continue. Global Fund hasn't gone anywhere. Which includes a lot of key populations work, so really critically important work. We are doing other types of work around mental health and things like that. One of the things that I think has come up a little bit in the webinar, but it's a really key tension in the HIV response often, is around integration of services and, the kind of HIV silo and how that all works. And I think that's a really difficult and important kind of conversation that needs to happen with the Department of Health. And Ndaviwe also mentioned that the HIV programs have got a lot of expertise that can be transferred. Like in that case, he was talking about COVID, but HIV is also a chronic disease. And so there's a lot of expertise and understanding that can be transferred to other chronic diseases and to other service provision. So yeah, we've drastically reduced what we are doing. We're still doing important technical work, and we're not going to stop doing it. There's some, I don't know if you saw the news about the Gates Foundation and accelerating funding. There are things happening, but it's in a totally different format to what it has been, and it's going to really change how health services look in South Africa in terms of the way that partners and the government have worked together, for sure.
I just want to follow up on 2 points. So yes, the news of the Gates Foundation today that they will accelerate funding, but also they will end all their funding in 2045, right? So it's only for the next 20 years we're looking at this. When you talk about integration, that's a way of saving money, right? To bring services together so that we can capitalize on treating things together. Is that what you're talking about? And also, can you give us a practical example of that? And why is there tension?
Yeah. I mean, if somebody goes into a clinic in South Africa, you're not going to be treated for HIV. You're going to be treated for whatever problems you have. The nurse is not specific to HIV. The nurse deals with everything. But there's a lot of it is money saving. It's the way that South Africa wants to do things. It's how primary care works. But there are very specific aspects to HIV that need to be managed intentionally and differently. And HIV is the biggest, we are the country with the biggest HIV burden. It still remains our leading cause of death. Teenage adolescents and young women need to have services that suit them. So that's the kind of tension is between integrating everything, which is where it seems like the department is heading, but maintaining really critical services for key populations like some of the ones we have on the call, making sure that even though we are providing people with comprehensive services in the community, we still are differentiating care where we can. So it's a complicated, there's pros and cons to all the different ways of doing the service delivery, and we have to recognize that integration is a really key part of how the Department of Health wants to provide care, and see how we can do that, but also differentiate and provide services that meet people's needs.
Thank you, Kate. Linda-Gail, I see your hand. I just want to go to Corley quickly because she raised the hand a little while ago and I skipped her. Corley, do you want to say something quickly?
Yes, I wanted to add that the association of these services undermines the advocacy work that I think we've done, we've started to do long back then. And I think Gail on the presentation indicated that 40 years of work that we've done in the country. So my other suggestion is to add that sensitization, I think it's going to be important, happening in parallel with the priority plan that I think will be put in place in terms of making sure that people are adhering to medication. Because my concern and my worry, especially around the HIV treatment and these programs that have been then reduced and stopped, they've been vital in delivering HIV prevention services, such as condoms, PrEP, and HIV testing. In a country like South Africa, where sex workers are more susceptible in contracting the HIV. So these programs are key in preventing the new infections, also in ongoing treatment. So for me, it is important that the sensitization training goes in parallel, because some of the healthy workers are going to continue, and some they've been doing this, as I stated earlier, that due to pressure and the number of people that we're going to be accessing services, it's going to be very, very, very challenging. And these services were also important for sex workers and essential health care services that WRHI and other organizations, ANOVA and other organizations that I think we've been working with, including they've been vital beyond HIV, also including sexual reproductive, the mental healthy state. It has escalated to another level. That is also something that I think it's important that we were looking into in terms of making sure that the situation sort of like get back into normal. It's not going to be an overnight, we understand, but not having these services, it's a barrier itself in accessing the necessary medically, in particularly in the context of stigmatization and discrimination with the broader healthcare system for sex workers specific. Thanks.
Thanks, Corley. Linda-Gail?
Thanks, Mia. Yeah, I think, the comment about integration is an important one. And I would say that we were moving towards that space in the recognition that this epidemic isn't going away. I spoke about another 40 years. I mean, that's a conservative estimate. It's going to be with us for a couple more generations in the best sort of scenario. So how do we sustain our response? And this means we now need to integrate HIV within a broader sort of global health envelope. And so I think we were moving there. It obviously also is very important for the individual who, as I mentioned, our population's getting older, they have non-communicable diseases, they have other needs, colleagues, right? There's mental health, there's sexual reproductive health, there's tuberculosis. That needs to be integrated, and we meet the individual as a person where they are, but doing it in a hurry and without careful consideration, as Kate says, can risk some of the important sort of progress we've made. people are very good at dealing with people who are living with HIV. We are usually very sensitized individuals who understand that different populations need different things. And the concern is that if you kind of throw that out there as a free-for-all, that you lose a lot of that nuance and a lot of that specialty care. Now, I'll give you an example. I think there was a time, and probably this whole panel is too young to remember, there was a time when our nurses had carried a stripe on their epaulette that said they were contraceptive experts. And you became a nurse who was a contraceptive expert, and that was the person who gave out contraception in the clinics. And she knew whether you needed an implant, an IUD, a oral pill, or whatever. And then it got integrated, fully integrated in the system. And suddenly that expertise went away. And then all we were offering was injectable contraceptive, and choice went out the window. So I think, there are pros and cons, as Kate says. And at the same time, I think this is where we need to go. So, but, I think doing it in a hurry with not enough funds to think about it carefully. I will say to you that for the first time I've been involved in the target setting for UNAIDS for 2030. They will have integration targets this time. So the whole world is starting to embrace the fact that HIV now needs to be not an exceptional, vertical program. It needs to be integrated. But I think we all want to say, how do we do this carefully? And certainly I'm not thinking the best scenarios in the acute sort of crisis, but to think carefully about this is part of us thinking, how do we use our RANs carefully that not only addresses the first, second, and third 90, but also addresses the fourth 90, which I try to point out is so important.
So what's the most practical thing to start with integration? What's the thing
Well, I think South Africa's made quite a lot of headway on TB. That's the obvious one, right? Most people who have HIV also need to be tested for TB repeatedly, and vice versa. So I think we have made a lot of headway, and I would say our current health minister has been really important in that regard. When he was head of Stop TB, this was his passion, right? So I think really important for us to do. The next one that's very close to my heart is integrating sexual reproductive health, because, again, makes absolute sense. HIV is an STI, so how do we bring that together? And then I would say mental health follows very closely with that. And then the non-communicable diseases come along also along with that. So I would say there's some obvious ones that we need to think about in the short term. We know that the integrase inhibitors can lead to more weight gain. Weight gain leads to diabetes. So again, there's some obvious things that we need to bring together in that way.
Thanks, LGB. I would like to invite our audience, if you would like to make a comment on video, please just raise your hand and we will give you a chance to do so. Or if you wanted to ask a question on video. But importantly, if you feel that you also can contribute to what the panelists have said and you'd like to have a chance, just raise your hand and we will allow you to do so. In the meantime, I would like to read a comment and a question from Gwen Stevens. And she says, is the Department of Health considering to expand the use of mobile clinics for decentralized community healthcare service delivery to promote disease prevention and control in the proactive approach to curb the crisis we might see if we react? Does anyone feel comfortable? Because we clearly don't have the health department here, but does anyone want to comment on this or have any information as to what the health department might be considering on the panel? Doesn't look so yet, so let's move on. Linda-Gail raised the hand. LGB?
Yeah, so Mia, I would say to that, and hi Gwen, I would say to that certainly, as pointed out, I think by Sibongile or Koli, that the health department has entertained mobile clinics in the past. And of course, those of us in the NGO sector love mobile clinics because it brings the services to people where they are. And those of us who really care about person-centered care, this is a brilliant way to do it. I know the health department tends to shy away from mobiles simply because they can be more expensive, right? You provide one set of services, whereas a fixed facility can do a million things, from an ingrown toenail to baby delivery services. So this is where I think that tension starts to come in. But I think Gwyn is raising a very good point around, in the 21st century where we have AI and digital health and mobile health, is it not time to really think about these kind of more innovative ways of health delivery, at least for some aspects? And I think this is where the donor dollars have really been put to good use. That has enabled us to have community-based services, drop-in centers, other kinds of innovation. And I suppose it comes down to again our public sector saying the crazy thing not to do is to keep doing something that hasn't worked in the past. So if young people and LGBT and key populations are not going into our traditional health services, we either need to change those traditional health services or we need to offer some other kind of service. So what does that look like? And, again, you don't want to do that in the depth of a crisis, but at the same time, maybe the crisis becomes a catalyst for you to say, is it time for us to, investigate that? I would argue, and I know Higher Health has been asking this for 100 years, can we not offer HIV services from Higher Health, from TEVIT colleges and universities and even high schools, given that we have an unintended pregnancy epidemic as well as HIVs and STIs? Is it not time for us to say, can we not provide services in a mobile way or some other way to our high schools? These are things that obviously everybody feels very controversial about, but maybe this is the opportunity to say, how can we do things differently?
Thanks, LGB. Journalist here, Ida Uester, is asking, thinking about solutions, there will surely be some hard choices to be made and streamlined priorities. What gains will there be in this, and what unavoidable or regrettable losses will there be? Who would like to respond on the panel? I would imagine quite a few of you would have opinions on this. Let's start with maybe you, Kate.
Right. I was just deciding how to jump in. So I think there are a lot of things, and I think this is this interesting position that we're in. Efficiency is not really such a bad thing. It starts to seem like a dirty word, and but there are definitely places where we've been using resources perhaps inefficiently in some cases, but also, according to other people's priorities and not necessarily our own. And so that is what the opportunity is. There definitely are some services that we don't have that much evidence for that we have been putting in resources to. I'm thinking particularly perhaps, and it's a little bit, everyone's got their own opinions, but I'm thinking about tracing patients very early. So a lot of resources have gone into phoning people on the day that they missed their appointment, whereas perhaps we should be thinking about appointments more flexibly and allowing people more space to kind of live their lives and interacting with the clinic in a more flexible way. That's the word I'm looking for. So I think that's perhaps one area where we can drop certain things. It's not a lot, but there are going to be places where we can perhaps put less emphasis on things that maybe aren't our local priorities. So I think that there are some opportunities like that. there are going to be a lot of losses. You know, the NGOs did operate efficiently. And one of the things that I think is a real shame is that health management has really, you know, there's been a lot of talk about unnecessary management costs, unnecessary managers, you know, and in fact, managers are so necessary for health programs, and the management of our programs and our facilities is often kind of on the weaker side and really needs more, not less. So I think we need to be careful of that we don't trim the wrong things and leave, you know, thousands of counselors on the ground without any support, you know, which is kind of potentially what could happen. Plug in all these thousands and thousands of data capturers, but don't put in a level above to manage them, support them, train them, you know, so that is something that I think we need to really be careful of. And there's so much to talk about, but I just wanted to mention those two things.
Kate, that's a really interesting point that you're raising, because one of the ways that the health department says they're going to save money when they came to the amount of money that they would need to cope with the lack of Pepfar workers, was to say there are far too many managers. We'll just appoint workers into the primary healthcare system, then we don't need as many managers. And you've now pointed out, no, we do need the managers, right?
We really do. And it's in all the literature. If you look at any literature about community health workers, for example, how they are managed, how they are supported is critical to their success. And of course, the same with all kinds of health cadres, you know, the nursing management and facility management, their whole fields of study around these things, and they're critical. And so it just was very difficult to kind of read that and think, you know, really this really needs more emphasis and not less emphasis. And it was a bit disappointing, that piece.
Thanks, Kate. Linda-Gail, would you be interested in also sharing your opinion on this? What would be the unavoidable losses that we're going to face, or regrettable losses, when we need to make some hard choices about how will we streamline things if we don't have enough money?
Yeah, it is quite a tough one, because there's just too many competing interests. If you look at the first 95, second 95, third 95, so that will need us to prioritize. But I'm thinking there are some things probably that they don't need much money. I mean, we know that PrEP works. If you look at our targets, I was looking at the slide by Professor Linda-Gail Bekker. I don't think we're reaching our targets in terms of PrEP. So that doesn't need money. It needs more communication to tell people that PrEP works. It prevents HIV. I saw a very interesting question on the Q&A about if people know the U is equal to U, right? I don't think people know much about that. So if you can tell the people that if you're undetectable, it's equal to untransmittable, just to encourage people that they know that if they take the ARVs, they'll be able to transmit HIV to their loved ones, to their partners. So those things don't need much money. Maybe we need more communication. It's a time of social media. There's TikTok, there's Twitter, you know, there's people who are called influencers. But I never say anything about PrEP if I get in on Twitter, you know, or Facebook. So maybe those are the simple things that we can do. And in terms of integration, because I've worked also at the clinics, remember currently we have a nurse who is NEMAT trained. So the nurse who's trained to issue out ARVs or manage people living with HIV. But that it looks like it's not going to be sustainable, because it looks like as our population is growing older, it means now every nurse in the clinic must be NEMAT trained. So everyone in the clinic must know on how to manage HIV, nurses that manage people on chronic diseases, nurses that work on the acute department. So it looks like there's the NEMAT training should be for everyone now in the clinic, because our population of people living with HIV is growing older, and they're getting a lot of diseases, And so it means every healthcare worker must be able to understand something about HIV. So those are the few things I can think about now. Thank you.
Thanks very much. I'm going to read a last comment and question from one of our audience members, Michelle Zuckerman. She's saying there are repeated calls for unique identifying numbers, minimize baby to testing. Where are we at with this? Does anyone know on the panel?
I mean, it depends who you ask. I think that's really the answer to that question. And but this is one thing where NHI really could move us forward, because you cannot have an NHI without a unique identifier. And there are plans in place for what the department is going to use. So I think the department has their unique identifier. They know what they want to implement, and depending on who you ask at what levels, you'll get a different answer as to how effectively that's been implemented so far. But yeah, it's all about the implementation of the system. You know, the HPRS it has been identified as the system. We've got the system, but how it's actually being implemented on the ground really varies according to where you are.
Thanks, Kate. And Michelle has another question about the awareness of viral load. As what are the reasons that we as healthcare providers have not done this better until now? Maybe Kate and Linda-Gail and also Ndubube. Yeah.
Yeah, I think, yeah, that's what I tried to say. I think it was from that question, because I think it's a very important point that people who are virally suppressed won't transmit HIV. I think that information has to get to the community, has to get to the patients. But I mean, if you look, if you are being fair at the clinic, there's a long queue. The nurse or a doctor or medical officer is managing the patient clinically, and there's a long queue. So I think clinicians then don't have time to do it. So that's why I'm saying maybe we should look at ways, maybe communication, more education, more TV programs. You know, we used to have TV programs about these things, because I think clinicians, if you look, I mean, to be fair, the queues are too long at the clinic. Maybe we sometimes forget to say, you know what, if your viral load is suppressed, are you aware that you won't be able to transmit HIV to your partner? And that is important. You're saving yourself by being suppressed, and also your loved one. So, but then I think, who does it? Is it the clinician? Is it, should we have people like ANOVA, probably, that tent where they've got a small tent there, they're talking to patients? Should we have TV programs? Should we go on Twitter? Should we go on TikTok, you know? But I think it's important information that must go out there, including PrEP. I don't see those that information being out there. Thank you.
Thanks, Ndubube. I'm going to ask for us to end, because there's about 12 minutes left, for each panelist to end with telling us what would be the biggest bang for our buck right now? If they could say, what is the thing that we now in the next 6 months need to try and do with less money, but that will help us in the bigger context of things to make progress despite the lack of funds that we have. I'm going to start with Kate. I'm just going to do the names as they appear on my screen. So I'm going to just follow that order. Kate.
I think one of the things that's really important is to maintain the differentiated services that we have gotten to so far. So that's the CCMDD program that allows people to pick up medication at a pickup point, whether it's a Clicks or a Dischem or a whatever, a GP, or in some cases at the clinic. E-lockers, you know, there's various modalities that people can pick up their meds in a much quicker and much more convenient way, much more private way. And I feel like that kind of service delivery is a win for everybody, and it would be a real shame to backtrack on any of that. And it includes NCDs and other medications. So I think it would be really, really critical to maintain that.
Thanks, Kate. Linda-Gail?
Yeah, I mean, Mia, I'm going to have to say that we cannot lose our grip on prevention. And so that's my huge concern, that when the chips are down, we will focus on treatment because people die, and that's not great for politics. But if we don't stay ahead of prevention, we are not going to win the 2030 goal, and we won't bring this epidemic to its end, and the whole thing is going to be dragged out for a lot longer. Of course, that raises the questions of PrEP and other forms of PrEP, and that, of course, is a whole nother conversation we didn't even have this evening. But who's going to purchase long-acting PrEP, which we've all agreed could be a game changer and bring, you know, an end to new infections a lot sooner, as well as stop vertical transmission. So I'm just going to put primary prevention there, and particularly pre-exposure prophylaxis on the radar.
Thanks, LGB. Ndivibwe?
Okay, yes, I think I was also going to add on prevention. Prevention, I think that is very important, and diagnosing the people who are not aware of the HIV status, make sure they get to treatment. But some things that don't need money is leadership. Of course, we need leadership. We need community mobilization. That's not need much money. We need education and advocacy. So I think those are the things I will list. Thank you.
Thanks, Ndivibwe. Corley?
Thank you so much. The meeting has been a very productive one. I think I've got 2 things to add. I've been typing on the chat because I'm talkative. So I'm like, okay, let me type so that we can get information there. I think also it would be good to government to sort of like have a station desk within the healthy facilities so that we are able to welcome our communities and refer them. And we're also happy and available to do the educational awareness and healthy, because we're an expert on that. As it has been indicated, that education, I think, on society and everyone, because I noticed that also, even if you go for HIV test in healthy facilities of government, sometimes they don't get to ask you to do the pre and post. So people are missing out, because as much as people are using PrEP, those are education that we need to say the 95 is covered by the condom and the 5% is covered by the PrEP. So those are kind of education in order for us by 2030, we have reached the 95, and maybe by that time it will be 100, 200. So we are available. I think the communities, key populations also should be utilized as tools, because this is within the scope of our industry. So we're really looking forward and happy to target our clients also, and sex workers. So we want government to come on board and just give us this platform and have a desk, because as an organization, we don't advocate for specific clinics for key communities, because we know that will create a stigma. We're advocating for equal access. That means our communities also should learn to access services. People should stop complaining about, I was at the clinic at 6, I'm leaving at 4. The important thing is that you've gotten the services that you're looking for. I personally, as the National Director, Officer Songe, I'm using the government facilities. My clinic is in Cape Town. So I've not have any stress, because I need services, and then if I get them, that's all important. Because sometimes I'll ask sex workers during workshops that when you take your kids for a clinic, what time do you go? And she'll like, I'm waking up at 4. I'm like, and then to be there at 5:30, I'm like, what's difficult then to do that? Also for us, I think as key communities and leaders, we shouldn't babysit our communities, because we're not teaching anything. We don't need priority services there or to be treated especially, but we need equal services. So we're availing ourselves as a Songe, because we've trained our peer educators. They've got knowledge in training, in doing sensitization, but also in educational. So this is the team, I think the collaborative that is also needed, so that we make sure that our communities do access these services. Thank you.
Thanks very much, Corley. Let's end with Sibongile.
We did this before. We worked together. We as community activists, researchers, clinicians, and everyone, to force our government to make sure that today we have more than 5 million people on treatment, and we can still do it to maintain that number of people on treatment by working together and put more pressure on our government to make sure that they take a lead. If we once did it, then we can do it again. So that will be my ending note to say we need to work together. We need to put pressure. We need to make sure that we continue to save lives as much as we can. Thank you, Mia.
Thanks very much, Sibongile. And that brings us to the end of our discussion. I must say, for me as a journalist, what I would love to know answers and look at stories after the really important points that you raised is the one thing that Linda-Gail raised was who will pay for long-acting PrEP? Who will fund this? And the second thing is, why did COVID bring everyone together, especially the private and public sector? And why does this seem to divide us? What's the difference between the two crises? That's interesting things for me as a journalist to think about. And I think that we all need to try and figure out answers to see if that could help us to come up with solutions. This discussion will be available again on Tuesday between 1 and 3, and I'm going to ask Valencia from the Clinician Society to explain how that will work. But in addition to that, the recordings will also be available on the Clinician Society website, and it will also be on Bhekisisa's website within the next couple of days. Valencia, do you just want to explain how the rebroadcast between 1 and 3 on Tuesday will work?
Thank you, Mia. So as you registered for this webinar, you had a second link to register for Wednesday. So not everyone, some people knock off at 5, 6, and so they're on the road now. And so we've made the recording available, the recording of this live session available to those that could not attend, and be able to also obtain CPD points for those that require CPD points. Yeah, on Tuesday, 1 to 3 o'clock. Thank you.
Thank you very much, Valencia. And I would like to thank all the panelists for their time. You are busy people and you have such great access to knowledge, and you have a lot of patience to sit here for so long and share all your insights and your knowledge. Thank you very, very much for that. And I also saw many journalists here on the list of people who attended. So thank you from the media side as well. Go well, and I really hope we get to a solution and to ways to cope with this in the next couple of months and coming year so that we get somewhere. And it's with people like you that we will.
Thanks, Mia. Take care.
Thank you.
Okay.
Thanks so
Thanks,
much.
everyone. Bye.
Yes, bye.
Bye-bye.
Thank you. Good evening.